Hi, this is Stephen, and in this video we will discuss normal and abnormal M mode, looking at the left ventricle. And just as a reminder, you have your peristernal long axis view here, with your left atrium that empties into the left ventricle via the mitral valve. I'm just shading in the left ventricle here. And you can slice it with M mode right here and look at the movement along this line with better temporal resolution. And I'll just mention that sometimes this confuses people, but you can also do the same looking at your left ventricle in the peristernal short axis. So we just took our probe on the patient, rotated it 90 degrees, and then we can slice. You might see actually your papillaries maybe over here and over here, and we're slicing somewhere here, right through. Remember, M mode, the goal is better temporal resolution. We'll say approximately 10 times better temporal resolution than traditional 2D echo. So what will we see when we slice through the left ventricle? Well, your normal M mode will look something like this. Let's add a little bit of thickness to the left ventricle. And then I'm going to add in the right ventricle up here. This line here, that's the wall of the right ventricle. This is your septum in the middle. And this is your posterior wall down here. And you can see that it contracts in for systole, it's squeezing, and then it opens up for diastole, squeezes for systole, opens up for diastole, systole, diastole. Now, what would you see if you had increased abdominal pressures? And so we'll write each of those scenarios here. So if you have increased abdominal pressure, that is pushing up against the, so you have increased pressure that is pushing up against the inferior wall. You'll see something like this. And I'm gonna, for time's sake, I'm not gonna draw the right ventricle. I'm just gonna draw the septum and the posterior wall. So you'll see that the septum is moving normally, but you'll see that the posterior wall is flattened by that increased pressure. Something like this. The posterior wall is not moving as it should because of that increased pressure below. Similarly, or conversely, what if you have right ventricular pressure overload? Increased RV pressure. You'll recall that in the peristernal short axis, you may see the D sign, where you've got your left ventricle, instead of being round like it should, this is your LV and your RV. And you can see how the septum is flattened and not moving as it should. So what will you see? Well, you'll see that this time your posterior wall is moving normally, but your interventricular septum is just flattened and not moving at all with systole or diastole. That would be what you'd see with significant right ventricular volume and pressure overload. All right, what might you see if you had a history of cardiac surgery? So the history of cardiac surgery, you'll see something interesting. You'll see that the two walls actually move together because the heart's swinging. So we'll add in some thickness here. Right, so instead of in systole both contracting together nicely, the heart's swinging, and your septum actually moves up and away during systole, and then they move down together in diastole, systole, diastole, systole. What might you see in a patient with a left bundle? So in a patient with a left bundle branch block, you'll see, let me draw your posterior wall here first. What do you see with your septum? Well, you'll see that the septum actually starts moving quicker, and then it's still, and then it contracts again. So something like this. Why? Well, let's look at if this is your heart here with its conduction system. Normally, you should conduct down both the right ventricle and down the left ventricle at the same time, and your septum and the posterior wall should all be activated together. If you have a left bundle, that means that your electricity, so that means you have some kind of a break here, and so your septum contracts first. Your septum contracts first. That's this initial movement right here, early, before the ventricle, and then the lateral wall that catches up later. That's where you have this. So there's not good synchronization between the two walls. You have your septum moving first, and then it stops, and then it kind of stutters and moves again in an uncoordinated manner. And then one last one that I'll mention. For this, I'm going to include the mitral valve as well. So technically this is a slightly different M-mode slice, but it's still related to the ventricle. So this is if we have a decreased ejection fraction, you'll see something like this. You'll see less contraction here. Right, the wall's relatively flat. We don't calculate ejection fraction from this view because because we're just looking along a line, and you may not have sliced it in the optimal way. But what you can actually look at is you can look at the mitral valve. Remember, the mitral valve is open during diastole, closed in systole, open in diastole, closed in systole, open in diastole, and you measure this distance. The separation between your early wave, the E, and your septum, E point septal separation. If that is large, as I've drawn here, if that early wave doesn't come close to the septum, that's a sign of a reduced ejection fraction. And so these are some of the different patterns that we can look at when we're slicing with our M mode through the left ventricle. We can take advantage of the better temporal resolution. If you see that either one of the walls is not moving, you think that is there some pressure that's preventing either your septum or your inferior wall from moving, or you can look at the timing and see that both walls are swinging together, like in cardiac surgery, that there's some dyssynchrony as you'd see in left bundle, or just looking at this distance, this EPSS, to show that there's a decreased ejection fraction.